Hi, this is Brian Kim. I'm going to share with you this case of a patient who actually referred himself to me. This patient's from overseas. He had some trouble with his eye, and so he reached out to me. We corresponded online, and basically he gave me all of his medical information, and he decided to come see me for his case. So this patient had retinal detachment and then subsequently developed a cataract, had cataract surgery, but then had a dislocated lens, had refixation 5 times. So refixation with suture fixation to the iris, suture fixation to the sclera, and scleral fixation as well. So this is how the patient looks. You can see the lens is dislocated infratemporally, and this is a slit lamp video of the eye. You can see there's not much IOL denisis. It's not shaking much at all. It's well fixed. It's secure. It's just decentered. And so again, it's not falling. It's not slipping, but clearly it's not sitting properly. And so this patient came to see me for this. Now, apparently this patient has a Sensar AR40 lens. And so I asked him, should I try to keep the lens? And he says to me, well, I think they did a lot of manipulation to the haptics, and so maybe you should take it out. So he's rather well informed about his surgery. So I dried the surface of the eye with the Wexel sponges, and then I ink the limbus on the right side and then the left side using the cannula to find 180 degrees apart. And this is a fixed caliper. I'm indenting the sclera 2.5 millimeters posterior to that mark, and then 2 millimeters adjacent, 2.5 millimeters posterior and in radial fashion to that limbal mark, and then 2 millimeters adjacent. And then I'm going to ink the scleral indentations. We'll do the same thing on the left side. And remember, I like to mark in the neutral position, because if I mark in the neutral position and I fixate the needle to the sclera in the neutral position, then my marks will reflect the intended scleral needle placement. Make the scleral indentations, and then again mark with the tip of the 27 gauge cannula. I switch to the cotton tip, which gives me more control, and I'm rolling the eye up towards me, and I'm sitting supratemporally. I'm making my contralateral limbal incision, which is at right angles to the marks, and that is to externalize the leading haptic. And this incision is for the 22 gauge thin-walled AC maintainer. This left side incision as well as this right side incision are for the explantation of this dislocated lens. Injecting intracameral epinephrine and then some dispersive viscoelastic to coat the corneal endothelium. You can see the lens is rather stable, but it's obviously dislocated. Holding the eye with the cannula, this is the 3 millimeter blade. I'm going to make that incision perpendicular to my ink marks. I make a vertical groove, tunnel through the cornea, and then I go in. Using microforceps to grasp the distal haptic, I'm trying to pull it up, but I can see that it's tethered. And so I'm using 2 hands, and then suddenly there's a loss of resistance. And you can see that the tip of the haptic had some material, looks like some uveal material or something. And then I'm trying to get subincisional to the trailing haptic. I'm able to grab it here using a 2-handed technique, using 2 microforceps. And again, I can feel that it's tethered. So I'm trying to inch my way up towards the tip. But again, it is tethered to something. I'm inching across, and then I feel a sudden loss of resistance, and it pops off. So now both haptics are free. I switch to the micro scissor, and I go ahead and cut the lens in half. Disengage the lens from the forceps, pushing it away with the scissor, switching to 2 forceps now, grabbing the cut edge, and then pulling that right side piece out, and then using the other forceps to shield the cornea so I don't scrape the corneal endothelium. grabbing the distal end of the cut edge of the left side of the second piece, rotating it 180 degrees in such a way that the haptic then collapses on itself, and then I pull it out. This is a 25 gauge needle mounted on a 1 cc syringe with BSS. I'm angling it and bending it so the bevel will face to the right. This is the right side 30 gauge thin wall needle. I'm bending it in such a way that the bevel faces towards the main incision. And this is the left side 30 gauge thin wall needle, bending it in such a way that the bevel faces towards the contralateral limbal incision. This is a 22 gauge thin walled AC maintainer. Tape it down with some steri strips. This is the lens. I'm pushing cohesive viscoelastic through the barrel and on the platform of the cartridge, placing the lens on the cartridge, pushing down on the edges of the lens, getting it seated down, bending the wings so that the optic bends backwards. The leading haptic comes out straight through the barrel and the trailing haptic comes out through the back. Placing the cartridge into the injector, making sure that the trailing haptic is sticking up outside of the barrel. Pushing the plunger forward, advancing the lens, and I'm ready to go. This is a 25 gauge needle. I bend it in such a way that I'm able to access it easily, especially from an ergonomic perspective because the nose is in the way here. Place the injector inside the eye, have both bevels facing each other. The needle bevel is facing to the right and the injector bevel is facing to the left. Dock the haptic on the bevel of the needle and it goes right in. As my assistant advances the lens, the haptic goes into the needle more and I pull the needle out and it comes right out. Finish delivering the optic, making sure the trailing haptic comes outside the eye. I'm using a cannula to tuck the optic underneath the AC maintainer and pushing more dispersive viscoelastic. Holding the incision in this case, since there's no trocar because this patient's already been vitrectomized, holding the incision, turning water on, you want to stab the conjunctiva and sclera and then flatten out, advance the needle through the sclera, make sure you feel the resistance of the needle going through the sclera, and then you dive down. I'm using smooth microforceps. I'm sliding the trailing haptic into the eye, but as I do this, I notice that the leading haptic hasn't been externalized because it slipped in, and it caused the lens to sit a little funny. The point of doing this technique is to make sure the optic is pushed away from me, and it wasn't doing that. The leading haptic was actually compressed within the incision. And so I stopped, I pulled the leading haptic away again using a two-handed technique. I very carefully inched my way towards grasping the trailing haptic and then lifting it and just gently externalizing the trailing haptic and then making sure the optic is underneath the AC maintainer, and then I start over. When in doubt and when you have trouble, just start again. And now look, see, the leading haptic is way outside and the optic is pushed away. This is the position you want to have. And so I go ahead and stab the conjunctiva and sclera once again. I stab and then I flatten out and then I turn on the infusion, make sure the eye is nice and firm. I tunnel 2 millimeters through the sclera and then I dive down. So now I have excellent position of the needle through the sclera. And then I use my smooth microforceps, gently sliding the trailing haptic into the eye. Docking the haptic on the bevel of the needle, and you see it goes right in. Just a couple of pushes is all you need. Disengage the needle from the syringe. Using microforceps, smooth forceps to internalize the leading haptic. Grasping the contralateral limbal incision with forceps. Stabbing the conjunctiva and sclera at the first mark. Turning on infusion. And then I'm going to tunnel towards the other mark. This patient has some thin sclera, so you can see here I'm kind of hesitating because I want to make sure I'm going through the sclera and I'm not prematurely entering. So I start and I stop and I start and I stop. Again, I'm trying to be very compulsive. I stab the conjunctiva at sclera at that first mark, and I make sure I'm really flat because I don't want to enter prematurely, and then I dive in. And so I feel very confident that I have a nice scleral shelf in this case. Using microforceps, again, smooth forceps to grasp the leading haptic, and I'm trying to align the leading haptic towards the needle. I dock it, and it goes right in. Really fast and efficient placement of the needle through the sclera. Pull both needles out just a little bit, and then I'm going to pull the left side needle all the way out, making sure I limit how much haptic comes out. Because if you let out too much haptic, you're going to cause more stress on the optic-haptic junction. Don't externalize so much of the haptic. Turn off infusion. Use a Weck-Cel sponge to dry the surface. Cauterize the tip of the haptic and get a nice flange. Do the same thing on the other side. Again, as I pull the needle out, you want to limit how much of the haptic comes out. If you allow too much haptic to come out of the eye, then it's going to cause more strain on the optic-haptic junction. So limit how much haptic comes out of the eye. Drying the surface of the eye once again, turning off infusion, cauterizing the tip of the haptic to get a nice flange. And that is the end of the case. You can see a nice flat profile and approach of the haptic sitting on the sclera. I push the haptic into the sclera, reapproximating the conjunctiva, and you have a perfectly well-centered lens in the proper orientation without tilt. And this is the surgical PI using the vitrector. I turn the port down, start the iridectomy, but you don't want to go all the way out to the angle because you can eat the ciliary body, and start to do a little bit more vitrectomy. Again, remember, this patient had vitrectomy already. He had a retinal detachment. Since I'm already in there, I had the PI done. I went ahead and finished off vitrectomy, partly to just remove some of that viscoelastic as well. Place a tenonylon suture, take the AC maintainer out, and then hydromine incisions, and that's the end of the case. So this patient had a dislocated IOL due to complicated cataract surgery, which was caused by retinal detachment surgery. So the patient's fairly young. He had a dislocated IOL, refixated with the iris suturing. That failed. He had scleral fixation with suturing. That failed. And then apparently he had some flanges made to the lens, because when I took this Sensar lens out, there were some tiny flanges on there. Not sure how it was fixated, because he told me that these lenses were not secured by the Yamane technique. And so I was able to pop these haptics up. Thankfully, I grasped the haptics and I didn't grasp the optics, because what you wouldn't want to do is pull on the optic and then pop the haptic off the optic. So I was able to pull on the haptics, get the entire haptic out of the eye, both haptics, bisected it, removed each piece, again, used my modified technique to externalize the leading haptic passively with a 25 gauge needle docking technique. And then by doing it this way, I'm able to externalize the leading haptic, push the optic away. You saw how easy I was able to cannulate the right side needle with a trailing haptic, again docking the haptic on the bevel of the needle, and then performing the same technique on the left side. And the left side is so much easier because even though it's a second haptic, it's away from me, so the action is much easier from an ergonomic perspective. I pushed both haptics in, reapproximated conjunctiva, and this patient had a perfectly well-centered lens at the end of the case. And this patient left for his home country, and he is going to give us some feedback in a short while. But I'm very happy how he looked. Post-op day 1, he had a perfectly well-centered lens, clear cornea, good pressure, and he did very well. So I hope this was helpful to you, and I thank you for your attention.